healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Leaders in Healthcare. I'm Dr. Jordan Vollrath, physician, entrepreneur, and chief medical officer for Cherry Health. We're talking about all things healthcare. Join us as we speak to innovators, industry leaders, and the people working to drive the healthcare system forward. So today, tuning in all the way from Nashville, Tennessee, we are talking to Maria Flowers. She writes, speaks, trains, and consults on issues concerning health equity, patient safety, and social determinants of health. She's the CEO of Maria D. Flowers and Associates Consulting and is the founder of Safer Healthcare for All, a nonprofit organization dedicated to empowering the voice of the patient for safe and equitable healthcare. Maria has a doctorate of education from the University of Southern California and over 25 years experience in healthcare administration. Maria, thanks so much for taking the time to join us this afternoon.
Well, thank you so much for having me. It's a pleasure to be here.
So why don't we start out a little bit, like most of our audience, I'm going to say, is probably Canadian. Could you give us a little more insight on the healthcare system in the U.S.? You guys have your Medicare, Medicaid. We sit up here in Canada always, high on our throne of, we've got free healthcare for everybody. But I'd definitely love to learn a little bit more about how the American system works from that regard.
Yeah, so I'll try to take a stab at it and give you kind of a package, summary of how it works. But you can have coverage through your employer, which most people have. You can have coverage through the Medicare plan, which is either if you're a senior adult or if you have a low income. And then you can have coverage, which is kind of supplemental, through your state. And that's usually if you're low income or if you're a senior adult. Through what they call the Obamacare or the Affordable Care Act, that opened up that Medicare option to everyone. So everyone can go in there and purchase a Medicare plan on your own individually. And it's actually, you have to purchase one. If you don't, there's like a tax penalty for not purchasing the coverage. But obviously the best coverage that you're going to have is usually through your employer. They take the money off the top of your check each month. You sign up once a year for either yourself, your kids, your family, however many people are in your family, and they just take the money off the top. And you have, depending on, there's all kinds of, I don't want to get into all the idiosyncrasies of it, but some coverage is way better than others, where you have a copay you have to pay when you go to see the doctor or the emergency room. Some have, most will have a deductible that you have to meet each year. And once you meet that deductible, then all of your coverage is covered for the rest of the year. So usually, and that's how our insurance is through my husband's job. We have a deductible we have to meet as a family. Once we meet that, then it's like, woohoo, okay, let's get this done. Let's get this done. Let's get this done before the end of the year, because once January 1 hits, that amount rolls over again. So that's a little bit about how it is. It's very complex. It's very complicated to understand, but that's kind of a bit of a summary of how it works.
So you got a bit of a backstop, I guess. We've got like the low income, and then once you get to your senior age, then that starts to kick in. And then most people wind up trying to find coverage through their employer. What does that actually get you? Like for a standard, like here in Canada, you can go see the doctor as many times as you want. Like you can just keep trying to book in and go over and over again until the cows come home. You don't get any drugs unless you're admitted to a hospital, and then suddenly all the drugs are free for a week or a month or a couple months. You can't go to the dentist. You can't go to the chiropractor. You can't go see a physiotherapist. So that's all patient privately paid. Like, what does an average employer package cover? Because here in Canada, that's all that stuff that's what would then come from the employer side.
Got it. Okay, well, it's kind of similar here. So with your employer, you have your medical coverage. That's one coverage, and that's one cost. Then you have your dental. That's a cost. Your vision. That's a cost. Orthodontics may be a separate rider on top of the dental. Some coverage will give you the behavioral health. Some won't. They have some plans, and I'm trying to think of what it stands for, but it's called EAP, Employee Assistant Plan, I think is what it's called. And there's some behavioral health things that are rolled in there, where it allows you to see like so many, mental health sessions a year, and that's free. It's covered from your employer, so you don't have to pay a separate fee for that. You can go to the doctor as much as you want, as long as you pay your whatever your copay or whatever your deductible is. You can go see your doctors, as much as you want, but it's usually, you see your doctor once or twice a year, depending on what, your age or what you have going on. Then they'll refer you. So if you need to see like a cardiologist, I can't just say, oh, I want to go see this cardiologist, or I think I need to see a pulmonologist. I can't do that under most plans. I have to see my primary care physician first, and then they have to refer you to the specialist that you see. They have to give you the referral. Your doctor, your primary care doctor or your specialist usually controls the type of prescriptions you get. If you go to the urgent care or emergency room, sometimes they'll send you home with, something depending on what happened, but that's usually how it goes. But the pharmacy coverage is something different as well. And depending on how your coverage is will determine how much you pay. So I could pay, for, I don't know, asthma medicine, right? My cost for the asthma medicine could be $2, and someone else may be paying $30 or $100 a month for that same asthma medication.
And that's just due to the copay, or that's due to like the negotiation through the insurance company with the
Yep,
pharmaceutical company?
correct. That's through the negotiation of the whoever your coverage is. It's PBM, Pharmacy Benefits Manager. So whoever manages your pharmacy benefits to the pharmacy that you're going to. And that gets even more complex, because I can have the same insurance coverage. We could both have the same pharmacy coverage, you and I, but if I work for a different employer and I have a different pharmacy benefits manager, that can dictate if I'm even able to get that prescription, if it's covered at all, and how much I pay for it.
Okay, so you got to really hope that your benefits manager, he or she, is on the ball.
Yeah, your doctor can say, hey, Maria needs this prescription. She has to have it. I feel she needs it. And the pharmacy benefits manager could say, no, well, I mean, she can have it, but we're not paying for it. So she can pay cash for it. And it could be, $3,000 a month or something like that. That happens all the time.
Oh, wow. Okay. Well, this is
Yeah.
like, I guess that variability is part of what makes it challenging, or at least that's like the horror stories that kind of dribble up north here. And the one other thing that you hear about all the time, like the ones that make the news headlines, are like the out of network. Like when you go to the
Oh, yeah.
doctor, but it was, the mile away from the hospital that your plan covered, and then suddenly they don't cover that specific doctor. Like, how often does that happen? Are people well aware that this is the case and they really try and avoid doing that, or is it just so kind of obfuscated that it's very difficult to navigate? This podcast was brought to you by Cherry Health, the healthcare jobs network with over 35,000 jobs across Canada and the US. Physicians, nurses, pharmacists, and all other healthcare professionals can sign up for free. Start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across North America. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum, with thousands of new jobs posted every week. www.cherry.health to get connected today.
Yeah. So, yes, that can happen. And it depends on so many different things. But it depends on really where you live. Um, Oh God, there's so many things that can go into that. But yes, it happens, and it can happen a lot. Normally, if I have, Cigna or United Health or whatever, then there may be like a different type of United Health Plus or Cigna Health First or something. And then you have to see what physicians are in network. There'll be an in-network cost, and then there'll be an out-of-network cost. And so that out-of-network cost will always be higher than the in-network cost. And sometimes you just want to go to Dr. John, and Dr. John's been your doctor for 20 years, but now all of a sudden Dr. John isn't with he has Cigna, but he doesn't have Cigna Plus. So now he's out of network for you. And so Dr. John is going to cost you more than he used to cost you because now he's not in network. But then maybe next year he may be back in network. So you don't know. It's really crazy.
Why do they set it up like that? Like, is there just too many doctors to reasonably have every insurance company have an individual contract with? So they just choose, I don't know, 20% of the doctors in an area just for simplicity? Or why do they actually do that way?
I have my speculations. I don't know why, but I always say follow the money. It's always here, it's always, leads back to the money. So it's going to be, can I get the maximum reimbursement from this physician for whatever it is Maria's going to see this doctor for Maria's age range, for whatever Maria's diagnoses are. How am I going to maximize the reimbursement that I'm going to get off of this visit? And that's usually what it boils down to, and that's usually how those benefits are arranged, so they can maximize reimbursements. And it goes into quality, it goes into credentialing. I don't know how you all do it in Canada, where you, Dr. Jordan, want to work at ABC Hospital, right? You have to be sanctioned through that hospital to work for them. You have to go through a credentialing process to be billed through United Healthcare, Cigna, or whatever. So United could approve you, and Cigna could be like, we don't want him. And so then you're at that hospital, they take all these insurances, but you can only get reimbursed through this insurance. So it is, as I'm talking through it, it sounds like crazy town, and it is, but yeah.
Well, it's interesting as well. Like, I wonder how much of that value calculation weighs in. Like here in Canada, or specifically the fee-for-service system here in Alberta, every doctor who has a certain license, or if you're a family doctor and you do a specific type of patient encounter, like if it's suturing something, or if it's talking about mental health, or if it's just dealing with a wart or a cough or a cold, or you name it, they're all going to get paid the exact same. So there isn't really like a value of like, okay, well, Dr. X is 10% more accurate than Dr. Y. Like, I wonder how much that weighs into the insurance coverage down there. They're trying to get like the best bang for their money. Do they assess the quality of physicians on an individual basis, you think?
Well, okay. Whew. Now you're getting way in the weeds, but I'm gonna try to address it. So, because this is what I used to do on the corporate side. Yes, there are whole departments and I mean, it really is an equation. So we had a whole data team that really looked at this. It's not just the individual provider. Um, it's also that group of provider. It's also the organization they roll up onto, and it's also the patients. So, for example, if you're seeing, and this is where health equity comes into play, but if I am seeing patients in urban, New York City, and it's a low income area, high, non-English speaking population, low income, low education, high, disease population for diabetes, heart conditions, and all of that. My quality outcomes are going to be probably lower because I'm seeing higher risk patients, and they have a lot of comorbidities. And so for me to raise the quality of care and those outcomes, um, it's going to be more difficult for me to do that than it would be for you if you're seeing someone on the upper west side of New York, and these are very wealthy patients. They have great coverage, or they even are able to pay out of pocket. They see the doctor regularly. They don't have a lot of disease rates. The quality outcomes of your patients are going to be higher, and so those things are factored into reimbursement rates. So they'll look at me and say, well, gosh, all of your patients have heart disease, they have heart failure, and 10% of your patients had a stroke last year. And so that could impact the reimbursement rates that I have. And so larger companies, insurers, everyone is going to look at your mix, your patient mix, and your payer mix of how people are being paid for, or how you're being paid for these patients, if it's through Medicare, Medicaid, or through employer coverage benefits, because that's a different type of patient that you're going to have.
That's very interesting. And dude, I can certainly see how that would then play into the health equity. Because, yeah, somebody who is doctoring, I don't know, in a largely student population adjacent to university, right? They're going to be seeing young people with, generally much more mild and less complex multi-system disease versus somebody who, like you mentioned, is in a like lower socioeconomic neighborhood. Now suddenly you've got much more complex, chronic, multi-morbid, multi-system disease going on. Do they have a good answer to that, like when they're weighing out like who's doing a good job or who's not doing a good job? Because this is definitely part of where I think the Canadian healthcare system, at least in primary care, is a little bit superficial. Like we get some very rudimentary metrics of like, are you in the top quartile of prescribers for volumes of, abusable, divertible, high risk medications, or how many antibiotics are you using? But when it comes to like, are you doing a good job or not, it is very light.
Yeah, it's um again complex, but yes, there are ways to look at that. So there's patient experience surveys, depending on the hospital you have, the accreditation that they have. You can do patient experience, patient satisfaction surveys. So someone could say, uh, Maria is a horrible doctor. She did this. If I have tons of patients that are doing that, that goes into that equation, right? You have very low scores as far as your patient experience, that can definitely impact reimbursement as well as the other things. So there's a lot of different components that go into these decisions. And that's why a lot of companies invest so much in data teams, reporting teams. Their sole job, I mean, it may be called the quality department, but it's really a lot of analysts looking at all of these different, you know, data attributes to say, okay, what is the best grouping for these physicians? What is the best, organization to put these physicians in? This is normally able to be done on companies that service patients throughout the country. So they're in multiple states. They have a little more, I guess, some freedom in how they're able to associate these physicians in certain organizations
And
within the company.
how big of a company would typically be owning clinics like that? Like here in Canada, single mom and pop shop small businesses is like pretty much the standard ammo. Maybe there's an umbrella with 2 or 4, or in like the largest cases in the whole country, like a dozen or 15 clinics together. But for the vast majority, it's just these small individual business units, and there isn't really that middle layer of administration or oversight or watching KPIs or looking at like the business metrics and the outcomes as much. How does it actually work down there for the most part?
Well, it's turned upside down here. So the mom and pop physician offices that I went to when I was younger, there are very few and far between now, because of the quality metrics and the what they call government programs, Affordable Care Act, all those different plans. It has made it very labor intensive for a small physician's office to be able to keep up with the documentation that's needed to prove what their reimbursement is. So a lot of these smaller physician clinics, physician ran facilities, and just basic doctor's office have gotten swallowed up by larger conglomerates. And so there's some major players. There's in some areas there may be healthcare monopolies. That's a big thing that's going on here. When healthcare is being discussed in the United States, it's being discussed on shareholder value, merger and acquisition, valuations, KPI, It's rarely discussed, which is very unfortunate and probably speaks to why we have the worst healthcare outcomes in amongst wealthy nations. It's always talked about in terms of dollars. Healthcare in the United States represents around one fourth of our national gross domestic product, but we're still the lowest achieving healthcare system in of wealthy global nations, which is scary. It shouldn't be that way, but those conversations or how the healthcare is delivered is usually through an umbrella organization, and that umbrella organization may have some partnership with a certain payer group, a certain pharmacy benefits management group. And so things start to, I mean, it's a monopoly. It's a monopoly. It's capitalism and healthcare.
How does that play out then in terms of the equity and the access to care? Again, that's probably one of the biggest challenges we're facing up here right now is access to care. Like, yes, you can get it for free if you can find a doctor, but most people, or not most people, but like a third, a quarter of Canadians right now just don't have access to a doctor unless your leg has been amputated. You go to the top of the line at the ER, but like just general day to day, week to week, kind of more routine things is very challenging to actually get in. How is that going down there?
Wow, that's interesting. I never knew that about the Canadian healthcare system. I guess from our perspective, we just think, everybody's got healthcare. Anytime I need to see a physician in Canada, I'm a Canadian citizen. I can just go. Um, so that's interesting to hear. Here, the access is a little different. So I may have coverage. I might have purchased a plan through the, Affordable Care Act marketplace, but maybe I live in a rural area, which the largest part of our country is rural areas, right? There's no hospitals there because hospitals can't make money there. There's not many physician offices there because they're not getting large reimbursement there either. Or there could be, I live in this area, but the nearest hospital is, I don't know, 40, 50 miles away. Or there's no ambulance service in the city that I live in. That happens a lot. And so access in that sense is, okay, there's nothing near me because I live in this remote area or not remote area, or it's just an undesirable area for healthcare business. That's usually what happens. In other places where there is a lot of healthcare, there's options, but the quality of care that you may receive may be very different than someone who of means that's able to just walk in and pay for their care. There's a lot of medical tourism, surprisingly, that comes here to the United States, where I have seen people from different countries buy out wings of a hospital, and so then the calendar shut down because Prince so and so, or Princess whoever is coming over to have a cardiology procedure, and they want that whole wing to themselves. I've seen that happen. That's been going on for decades.
Wow.
But it happens.
That is wild. I've never
Yeah.
seen that happen up here. I
Oh,
don't
it
know how
happens
many
here.
princes are coming to visit Alberta, Canada, though, I guess.
Well, it may not happen as much now since a lot of the hospital systems here have opened up other versions overseas. So I know some of the major cardiology clinics, like I think Cedar Sinai, and I know Cleveland Clinic have operations over in Dubai, Qatar, those areas, and so they are probably being serviced that way now. But it definitely was like that when I first started working in hospitals. We used to have that happen a lot.
And then, so the geographic location, that seems to be sort of a universal challenge, not just in the States, not just in Canada, but kind of everywhere. The further you get from urban centers, the harder it is to get access to tertiary care and just having more doctors around. What other types of patient populations have you been working with that really struggle with that equitable access?
Yeah, well, I'm glad that you brought up the geographical thing, because here in the United States, your zip code, just your zip code, determines your life expectancy, um, your medical outcomes, your quality of life. So I could live in a certain zip code. The zip code that I live in Tennessee is actually one of the healthiest zip codes in the state, which isn't saying much because I think Tennessee is like 48 out of 50 states with quality of healthcare, but it's one of the better ones. But I could probably go a couple miles down to another zip code that's in a more rural area, and their life expectancy could differ by 20 years. It's definitely true in urban areas, especially in areas like New York, where I could go 2 blocks and the socioeconomic makeup of that neighborhood is vastly different than the one I was just in. So that is a major thing, and it's really around economics. There's some historical implications to it, where there were things. I don't know if you're familiar with this term called redlining. Have you heard of that term?
Yep,
Okay,
yep.
so because of that, there are some neighborhoods that are historically underserved, and those communities may have worse health outcomes, worse life expectancy, worse maternal mortality than another neighborhood right across the highway.
Just because of who they let in and who could buy property, it really changed things for decades to come.
Correct. Because those areas were depleted of resources, um, purposefully depleted of resources. And so the communities that were there were, locked out of better education. It's sometimes better quality of air, depending on what, if there was a plant right down the street, what have you, that could have impacted the soil and the water and all that. So there's a lot of historical implications that are still challenging to overcome today.
And then what are your thoughts on sort of the changing of the guard here, the new administration coming in? I didn't hear a whole lot about healthcare policy in the news when it came to the recent election. It was all foreign policy, it was border and immigration. Is there any anticipated big changes coming now that the Trump administration is taking over?
Well, we're kind of in a state of I don't know, and embracing for the worst case scenario, I guess. And when I say worst case scenario, I mean in regards to equitable healthcare and even safe healthcare. Some of the appointments are to leadership of certain healthcare organizations like Department for Health and Human Services and Centers for Medicare and Medicaid Services are, I'll just say, interesting. And so, not quite sure what direction things will go in. I kind of project that equitable care efforts and initiatives may lose a lot of steam. They may lose focus. I don't know if they'll be eradicated altogether. They may be. I think this administration is going to be pro um, organization, pro big box organization. Any organization that is large and that is trying to and I won't try to use a negative terminology because I'm trying to speak how they would speak. I would say monopolize, but I would say that they would probably say capitalize on healthcare. I think those are the trends that we're going to see. We're going to see a lot of mergers and acquisitions, and I think by the time this is over, we're going to see fewer and fewer players in this space.
I guess just given what we know about Donald Trump and sort of business guy is his entire persona, it definitely makes sense that that would become more corporatized, I guess, in the healthcare world. And I can see that probably leading towards that economic divide in terms of access to care deepening.
Most definitely, yes. And then there's also the maternal health issue. I mean, we have a maternal health crisis here. And it's not just, it's spoken from the African American and indigenous population perspective a lot. However, there's a maternal health crisis here for all women, regardless of what nationality or race that you are. If I am a white woman and I live in a nice zip code in the United States, my maternal health is still way worse than it would be if I lived in Canada, or even if I lived in some countries like, some third world countries. The maternal health here is scary, and it's not just because of the abortion laws that are being or bans that are being promoted on the state level in some states. This was before that. It's not the safest place to have a child here.
Why is that? How so?
Well, I think a lot of things go into that as well. Um, there's, um, I'll say this. This is very stressful. This can be a very stressful place um, to try to navigate as anyone who's not a white cisgendered male. As a woman, there's a certain type of grind here that you have to make it on corporate levels that I don't think women in other countries are um, used to doing. In some countries, there's help, there's more community, there's more family, there's more a sense of culture, and it's not just the paper chase. So there's a lot of families coming around, there's a lot of help. Here it's not that way. It's kind of like, have your baby, get back to work in 4 to 6 weeks, you know put your baby in daycare and keep going. Send get somebody to watch your child while you're at work. So you're not really raising your own child. Your child's in daycare, your child's in school. You haven't fully healed from having a baby. You haven't even been given the time for your body to heal. There's something called the fourth trimester that I think some companies are starting to allow more time away, paid time away from work after you have a child. But that fourth trimester is just important as the first three. And a lot of times you don't get any pay for that. I have a friend that lives in UK, and I believe she got like a whole year off. And she was telling me she got a whole year off paid. And then like NHS was sending in it was some kind of respite care. Like someone was coming in to help her with the baby, um, did some light housekeeping. I was like, wow, that sounds like amazing. I remember when I had my son, I was like sneaking away to go take a nap in my car once I got back to work because I was so exhausted. And the rest of the world doesn't function that way. And I think that's the largest contributor to it. It's just like, okay, you had the baby, get back to work. There's not that, and there's kind of this, okay, have the babies, but you can get somebody else to raise them. Or if you're a woman, well, you should just be raising them. Don't worry about your career. Let the man go out there and bring the money home. So it's just kind of the antiquated thought about women and how they have babies and how they should be.
And how does that actually trickle into then the healthcare outcomes? What kind of like differences at a population level do you start to see?
So there's a lot of inflammatory response conditions, which is usually by chronic stress. And that is not just, it's exacerbated, right, in African American and indigenous populations, but it's not unique to those ethnicities and those races. Heart attack, stroke, depression, behavioral health is huge, and it does impact other areas. So there's a lot of hormones that happen, when you're pregnant and then have the baby and then you're nursing and all of that. And I don't think a lot of focus is given to the mental health piece of that. And so that perinatal health for the mom and for the baby is overlooked. And so that's where you see a lot of complications and a lot of problems that occur in that time frame.
Yeah, it definitely sounds like that. The fourth trimester, the postnatal period, is the the softer side of okay, now what, right? So maybe the delivery rates and maternal deaths and things are low, but like, how does that support then actually go out to the communities and to the families after there's a kid? And I remember reading a study, and it was saying that like I think it was the single largest factor in determining how the kid was performing in grade 2 or something like that early on in school was linked with the mom's mental health when the child was still an infant. Like this was like by far the biggest, more so than your zip code or your income or whatever else it was. Is like, is mom depressed? Is mom happy and doing well?
Yeah, I mean, I believe it. I've not read that particular study, but it makes perfect sense. Now, in Canada, what type of maternal leave is provided there?
I think it's, I'm kind of ballparking here, but I think it's like a year. I've had a few friends that were off for an extended period of time, like even 18 months. But I don't know if that was fully covered or if they just chose to go off for the extra period of time. But it's definitely like a year or 9 months or around that ballpark where you can get coverage. So it's definitely substantial.
Wow, yeah, that's major. So here, just to clarify, not every job offers paid maternity leave. And the job does not, I don't believe they have to offer paid. Now, I believe you get it's either 6 or 8 weeks of they call Family Medical Leave Act. So they will hold your job. You're not getting paid, but they'll hold your position for you to come back after, maternity leave. And then you can, if you have a job that will pay you for that leave, you get paid. In my situation, just to share, I don't think I was at my job long enough to get full pay. So I had to take like, I think it was like 60% of the pay. And I went on bed rest before I had my son for a couple months. That was my leave. The bed rest ate into my leave. So I had to go back to work at like 4 weeks because I had been on bed rest for 4 weeks. So when you look at that from a health equity perspective, if I'm working at I'm working at Walmart, I'm working at McDonald's or some one of those hourly type jobs where I don't even have this coverage. I don't have paid leave. I've got to get back to work because rent is due. I've got to buy groceries. I've got to buy, formula for my child, all these things. And so you just kind of suck it up, find someone to watch your child, and you go to work and you earn, the $15, $20 an hour, whatever the rate is now, which is not minimum wage. That's more than minimum wage. But anyway, you just go do what you have to do to keep your family together, to keep a roof over your head. And so that's where the disparities are. Because if you think about it, I'm a mom, single or even married, and I'm making a low income and I have a child, I can't take any time off. But we've got to keep these bills are going to keep coming. These bills don't care that I just had a baby. I've got to go to work. So I don't have time to sit and, snuggle with my new little baby and nurse and all that. I don't even have time to nurse. I can't do that. I might not even be able to get a pump to pump. I've got to go to work. So let me get this formula. Let me get this, this child in somebody's daycare somewhere, and let me get my butt back to work. That's the mentality here, and I think that's what contributes a lot to the maternal mortality rate here, because it's a that will kill you. The stress of that will kill you.
Yeah, the pressure is just on immediately from both
Yeah,
sides, and not just okay, you now have a human and you got to figure that out, but also straight back to the economic realities and the bills and everything.
yeah,
I guess what
yeah.
would you like to see going forwards from the leadership in healthcare at the bottom up level, discrepant or disparate from what's going on with the actual administration and the government? Like, what would you advise in terms of the leadership, the physicians, the organizations, and the institutions in charge of delivering care?
Oh gosh, well, I would have different expectations or different hopes for each of those levels, but I'll say this: my expectations unfortunately have lowered a little bit because of the change of the guard that's going to happen. I had a lot of hopes and expectations for what we thought was going to be the new administration because of the trajectory that we have been on. I think that health equity had got a lot of steam. There are a lot of legislation that was in place to really propel equitable practices within healthcare. Now, my hope and my prayer is that those things don't get taken away. If we can just keep those in long enough for us to see some change. I would love to see change on the medical school level. I would love to get back to what healthcare is supposed to be for healing, and not just for you know financial gain. When you put that financial gain in there, and that's the drive is, oh, I can make a lot of money in healthcare. You take away from, I'm here to help. I'm here to heal somebody. I'm here to be part of somebody's healing process. And I think that's what we really need to get back to. But I know that that may take a lot of change just culturally within the United States for that to even get there. But that's my big hairy, audacious goal for the United States is that we would just get back to the care level of healthcare to allow a physician to just really treat a patient and not have to look at some reimbursable metric of what things are going to be and if I can give you this medication, if it's going to be approved, and just this is what me as a doctor, this is what I think you need, this is what you need, this is how I'm going to treat you. I would love for it to go there.
How can individuals start to spearhead that type of change? Like when it comes from that groundswell, grassroots kind of bottom up, what would the initial stages of that even look like?
I'm so glad you asked that because I really believe now more than ever that grassroots effort is really what's going to drive this type of change and where this type of care is actually going to be accessible from. So support those community-based organizations, support and promote community engagement between the healthcare organization, healthcare providers, and the communities that they serve. Speak up, talk to your legislatures, let them know what you're seeing, and be aware of what's going on. Not just from your perspective and not just from a financialization perspective, but just from a care level. I think once people get to the humanness of it all, and realize that these are human beings, regardless of how much money is in their bank account or what they do or where they came from or what they look like, it's still a person at the end of the day that needs care and treatment. If we could get to that piece of it and really help support those organizations that are out there doing that level kind of work, I think we can really at least just support and help the most vulnerable people that are in our country.
Yeah, just getting back to that patient-centered, humanistic approach.
Yeah, most definitely.
Well, I guess before we wrap up for the afternoon here, anything else that you wanted to shout out?
Well, I mean, I love to, as you can tell, I love to talk. I love to talk about this. I love to bring awareness to, safe and equitable care. If anyone in your country has questions for me or wants to learn more, feel free to reach out. mariadflowers.com is my business website. I'm also on LinkedIn, same name, Maria D. Flowers. I've got a couple of different things coming out next year. I've got a book I participated in that talks about toxic work environments and how it impacts the health of African American women, and that'll be in the spring. And some other things that are coming out too. So happy to engage, happy to speak with anyone.
Amazing. Okay, well, Maria Flowers, thank you so much for the time this afternoon and best wishes with the book launch coming up here. Thank you again so much.
Thank you so much. I appreciate the opportunity.
I'm Dr. Jordan Vollrath, and you're listening to Leaders in Healthcare, brought to you by Cherry Health. Please like and subscribe for more engaging talks with leaders from across the healthcare industry.